so many of the patients see specialists. They see an ENT because they got tinnitus and ringing in their ears. They see a migraine doctor and get Botox because they have idiopathic or unknown cause migraine. They see an allergist because they've got hives, rheumatologists because they have muscle tenderness, diagnosed fibromyalgia, gastroenterologists, IBS. You've got to look at the whole person and put all the symptoms together, do the test or treat, and diagnose MCAS, which is present in 17% of the population.
Hey everyone, welcome back. I'm here again with good friend and colleague, someone who I really respect the research that you publish, Dr. Leonard Weinstock. Welcome back, Lenny.
Thank you so much, Michael.
You're working on a documentary right now. Maybe tell us a little bit about that, because it's a good prelude into the conversation that we'll have.
For me, this is the most exciting thing I've done in a decade. Literally, so many people need help, direction, awareness, compassion, with the triad. I call it the evil triad. Some people say it's a trifecta, but trifecta means you've won something at the races. Right. No, it's the evil triad. Mast cell activation syndrome, POTS, postural orthostatic tachycardia syndrome, and Ehlers-Danlos syndrome, of which there are 13 varieties, but the most common is hypermobile EDS, where people can bend their joints back into weird positions, but it affects so many things in the gut. And I think you'll be interested to know it can cause median arcuate ligament syndrome, vascular compression diseases, nutcracker syndrome that people have severe symptoms from, and severe nausea, SIBO, refractory SIBO because of the loopy-droopy effect on the small intestine, long mesentery, etc., and constipation. But this is all tied together with mast cell activation syndrome.
Maybe we start with a few definitions in case people haven't heard of these syndromes, because I want to make sure that people stay tuned in if they might have a presentation or symptoms that would pique their curiosity and maybe they want to have a follow-up investigation. Because I think a lot of what you're describing, it eludes detection, right? Because these things are not super prevalent. And I guess that's all relative, right? How do we define minimal versus highly prevalent? But let's start with defining MCAS, and then we can define POTS and EDS. Just kind of really brief, high level. These are the things that if you're struggling with, you might want to really pay attention to this conversation.
Absolutely. So MCAS, mast cell activation syndrome, actually occurs in 17% of the population. And it probably can trigger many cases of POTS, postural orthostatic tachycardia syndrome. And because of growth factors starting in childhood, it may elongate the tendons and ligaments and lead towards hypermobile EDS, Ehlers-Danlos syndrome. So MCAS, what you got is an overactive, uncontrolled mast cell, which can spit out up to 1,000 different chemicals and have 200 receptors on the mast cell. So it's activated by so many triggers.
And just for people who may not have heard the mast cell immune system we're thinking, but maybe give someone who hasn't heard the acronym before the short summary of what a mast cell is.
Yeah, sure. The mast cell, it lives in our bone marrow in a precursor form. Then when the body gets a burn, an injury, damage of any type, the mast cell wakes up, goes in the bloodstream, and goes to that site and orchestrates the appropriate amount of immune response needed and the inflammatory response needed to repair that condition. Now, if it's genetically altered by something that occurred in childhood, as it often does, it acts crazy. It lives longer and it activates other mast cells and other blood cells types, creating a hyperimmune status.
Right. Which is all too common, I think, we know this in Western countries, that via the hygiene hypothesis and with some of the gains we've made with less infectious disease, we're paying the piper on the other end with the immune system not having some of the natural training it needs to be attuned and not fall into some of these sort of cell-perpetuating inflammatory immune loops like you're describing. So, so we have MCAS, And that can present as a wide array of symptoms. I think you partially intonated that, but this is not surprising to people when we sort of convert it to the lay parlance of inflammation can manifest from the brain down through the toes, really. It just depends on how, for that individual, will it manifest. Correct. So I think MCAS, we cover a lot of people with the inflammatory tie-in. And probably most of our audience, or the highest percentage of our audience, has probably heard of MCAS and or gets that analogy. You tied it to predisposing someone to Ehlers-Danlos and also I think the POTS. So let's define those really quick so people know, again, is this another layer that may pertain to me?
Okay, but let me insert one item to your remark about immunity and our environment. Basically, we're getting mutations of the controller gene on the mast cell, and we're getting that from toxins in our environment. The water that we drink, the PFAS, the algae blooms, et cetera, et cetera, et cetera. Right. Radon, who knows? But it's giving us mutations, and that leads to MCAS. Now, the mast cells live at various surfaces in our mouth, our nose, our lungs, our gut. The GYN entry points all have mast cells and therefore give symptoms at those locations and distant. So let's say you eat gluten and it sets off a reaction in your gut. Well, it doesn't just hurt in the gut, it can give you hives.
Right.
Now, how does it relate to POTS? Well, the mast cell also lives in between the parasympathetic and sympathetic nerves and at blood vessel sites. And so this crazy mast cell starts activating and puts you into a sympathetic zone. Hypersympathetic zone leads towards tachycardia and to POTS, whereby when you stand up, you feel faint because your pulse goes 30 more points above baseline than normal.
Right.
And people faint.
And the most common symptoms of POTS, and I want to dig into this a little bit because we've been chronicling a lot of the research on stress, inflammation, the limbic system. I'm curious to kind of pick your brain on how much you think the limbic system ties in, but most common symptoms of POTS, I know it can be somewhat broad, and a lot of these things, many things in health and medicine are very broad in their presentation, but in your experience, what's the most common manifestation?
Okay, well, certainly near faint, and fainting, tachycardia, sweats, inability to contract your pupils so they're light sensitive. But the fact is that both MCAS and POTS are multisystemic disorders.
Yep.
Possibly because MCAS is causing POTS, and therefore it's going to share the same symptoms of fatigue, brain fog, muscle aching, GI symptoms. POTS, if you're trying to have a bowel movement and you can't relax the anal sphincter because you have too much sympathetic activity going on, guess what?
Fine.
You have to strain, and therefore pelvic floor dysfunction is a big part of POTS.
And Ehlers-Danlos, maybe a quick primer on that.
Right. So those are the stretchy joints. People get joint pain because they're overstretched, and they do things like ballet dancing and gymnastics, and they're getting injuries left and right because they're overstretching their joints. And as I mentioned, median arcuate ligament syndrome can cause problems. Every patient with Ehlers-Danlos syndrome, EDS, has back problems, one type or another. Also, they can get some weird things like leaks, spinal fluid leaks, leading to headaches when they stand up. And that can be improved by a blood patch. But again, when they were a child, as an infant, they weren't born with stretchy joints, but they developed in time. And that's where I think the mast cell comes in, creating growth factors.
So one of the things that I found helpful, curious your perspective on this, when we have all these different syndromes or conditions that have such overlap in the symptomatic presentation, I'll usually create a rank ordered list that's informed by biostatistics. What's most common, second most, third most, fourth most, fifth most. And sure, it's going to be nuance guided if there's any marked indicators in their presentation and their history. But we kind of start with this, okay, let's rank order from the thing that may affect 40% of the population down through the thing that affects 3%. Do you use a similar sort of hierarchy as you're trying to identify where to go with someone?
Yeah, to a variety of degrees. So, number one, I utilize the checklist, the mast cell mediator release syndrome, which I can supply to your audience. That was created by the doctor who discovered MCAS in 2007. And he found that a variety of symptoms, by tallying it up, increased your suspicion of a mast cell disorder. So
I think Lawrence Safran had mentioned this in the podcast a few years ago. I'm assuming it's the same questionnaire.
Yeah, right.
Okay.
Right. And then the latest version has intensity markers, 0 to 10.
Instead of zeros and one being more binary. Okay, gotcha.
Right, exactly. So when I see a patient very commonly with irritable bowel syndrome, quote, and chronic nausea, and I look at the review of systems and every box is checked, I say, okay, we're going to work you up for mast cell activation syndrome. That's on the one hand. I'll do blood tests, urine tests, and try them on mast cell therapy. And if I get a good response, guess what? They've got MCAS. Then, of course, at the bedside, I'll check their pulse. They'll be lying down on the gurney, and then they'll stand up, and I'll check their pulse, and then I'll do a bite and score exam for how flexible they are. And it's easy to check. So those are the ways I approach a complex patient. Now I'm really paying attention to psychological status, and we're about to submit a fantastic article on patients who have suffered their whole lifetime with psychological diseases, who then subsequently have been diagnosed with MCAS by me or my colleague at University of Buffalo. Then we treated them with simple medicine for the most part for MCAS, and all their psychological diseases got better. So this is like groundbreaking news. It's going to really be fantastic. We've got a psychiatrist at Washington U who's excited to be involved in the research. We've got a restless legs doctor at University of Vanderbilt who is interested in exploring this in his patients with narcolepsy and ADHD. And if we can make all these dots connected and make it so that you can get to one pinnacle, one mast cell, and get it better and control it, that would be incredibly exciting.
Yeah, no, I mean, I think the inflammation psychological tie-in is one that conventional medicine doesn't seem to be great. And when I say conventional medicine, I don't mean conventional doctors. I mean the conventional paradigm and training, which is good for certain things. But I think we're all on the same page with certain schools of thought excel for certain issues and conditions, and other schools of thought function better for others and also worse for some, which is why I always say, don't go to your, let's say, functional medicine GI doctor who's really focusing the functional care and try to get the most advanced colorectal cancer screening or whatever it is. There's different schools of thought. They're going to be better at different things. Whereas the conventional GI, and you'd be an exception to this, but they may not be super up to snub on low FODMAP diet, low histamine diet. So you want to have a team. That being said, I'm curious your approach on the mast cells, because, and I know we've discussed this before, I look at this kind of on a spectrum, and I think it is a little bit philosophical in terms of how we delineate when is this something that we can modulate the environment the person and their mast cells are in successfully, and when do they require more directive therapeutics for the mast cells. And again, it's not either or. I think it's just trying to figure out how do we determine the hierarchy of interventions that we run through. What are you finding to be the most effective therapeutics? And is there a certain sort of order, which I'm sure there is, that you're working through with these individuals?
Okay. Well, first of all, identify triggers. That's Dr. Moldering's mantra and Dr. Afrin's mantra, and I created a table for an upcoming article that identified 8 different categories, and several in those categories that are triggers that are remediable. Some, like, for instance, I have a patient who's going to be in this next case series who was a paint salesman, and the VOCs
Boy,
created and activated his mast cell.
sure.
Then I treated him with aggressive therapy. He got better. He stopped going to the emergency room with abdominal pain, nausea, diarrhea, but he didn't truly get better until he retired and stopped smelling paint. There are long triggers, such as dietary. If you can get find out if you're gluten, dairy, wheat.
Are you finding FODMAPs to be a trigger?
So the answer is yes. There's a study that looked at low FODMAP diet and the effect on histamine levels, and the ones who went low FODMAP dropped their histamine levels substantially. And so if
this was challenged. I know that Angela Pfeiffer was quite critical in her appraisal of this study, which I believe came from 2017, but there was a more recent review paper, either 2020 or 2021, that really corroborated that finding. So I just want to sort of footnote that for our audience, that it does seem that there's accumulating data suggesting that you can improve either DAO or histamine or both with a low FODMAP diet.
Right. So find your trigger. Just talked to somebody today who cannot fly from one location to another for this film that we're doing, this documentary, because she's well controlled, but the vibration of being an airplane will make her have an attack. So it's the wacky things that other doctors are going to say, now you're making it up. This is all in your head. And then that led to the death of this woman in New Zealand that was highly publicized last night. So you got to find your triggers. I have one woman who drove to see me from a distance, and in her rickety old truck where she had to use the clutch, all the vibration led towards marked swellings of her leg and abdominal pain every time she saw it. So subsequently did telemedicine.
Right.
So my basic approach is step 1, and that's discussed on my website, www.gidoctor.net, special services, research, publications, dial in onto the mast cell section, and it's under approach to MCAS. And basically step 1, antihistamines, H1H2 blocker, vitamin C and D, quercetin or leodolin, which are, as you know, flavonoids, and then low dose naltrexone, which helps 60% of my patients and gets them over the hump. And then there are steps 2, 3, 4, and experimental ones that we're doing. Let me step back for a second and throw the ball at you. How many of your patients are coming in who have had depression, anxiety disorders, and so forth, and either failed SSRIs or have become toxic from those drugs?
In terms of patients who present with either depression, anxiety, I would also put in there maybe insomnia as another neurological manifestation of inflammation in some cases. Off the top of my head, it's got to be at least 30%. It's a fairly common finding. How many have had negative reactions to SRIs or SSRIs? I'm not sure offhand, because I don't know that we have a sophisticated enough questionnaire to be pulling that data out. We'll get it through if someone gives us an extra context, but we're not specifically asking every patient. So it's hard for me to accurately answer that question.
So you heard me mention that I use 3 nutraceuticals, if you will, vitamins C and D and flavonoids. But I also use other things such as CBD, THC, especially CBD, THC for insomnia. And guess what? There's a cannabinoid receptor on the mast cell that's on the deactivating side. And then NAC, NAD, especially if they have long COVID, NAD and low-dose naltrexone combo, because the virus activates mast cell disease.
Right.
And a 60-year-old drug that has anti-serotonin properties, cyproheptadine, published on acute COVID with that, with enteritis, but I used it for long COVID as well.
Tying in and stepping back to the psychological piece, I think one of the factors that's challenging for clinicians who really believe the patient, meaning we're not going to say, oh, it's all in your head, it's all psychosomatic, but rather, okay, there's something here we want to probe into and figure out what that thing or things are. In some cases, my observation has been that there is a brain to, I would argue, both gut and immune system feed in. And there's some data that's been really elegant over the past year, looking at functional MRI scans of the limbic center of the brain and correlating that so elegantly with blood that's more inflammatory. So we know that the limbic system can ramp up and make someone more reactive. And while the data here are early, there are at least data with programs like the Gupta limbic retraining program showing improvements in subjectives, not so much in inflammatory markers, but at least people are reporting that they feel better, they have better function, they have less reactivity. One of the ways I look at this is if there's just so much emotionality associated with, an individual is just hyper attentive and they're logging everything and they can't make heads or tails. And there might also be a history of some sort of trauma or even current trauma. Some intervention, whether it's limbic retraining, we're also experimenting with referring people to ketamine clinics, and we're excitedly awaiting a couple of clinics about to pop up in Oregon or Washington that are doing psilocybin-assisted psychotherapy and just looking at similar models showing efficacy, whether it be anxiety, depression, substance abuse. So there does seem to be, for some people, a real need to tend to what's going on neurologically. And not to say it's all in your head, but there is something in your head that could be supported to reduce some of this inflammation. How are you looking at this? Are you referring for limbic retraining or CBT? And what are your observations with that realm of intervention?
Well, let's dial back to basic science. And I have a wonderful slide in one of my presentations that looks at the brain and looks at the gut simultaneously on the slide. And it lists the chemicals that come out of the brain under stress that are activating mast cells in the periphery. And then we've got a leaky blood-brain barrier because of dysfunctional mast cells. That lets the chemicals in from the mast cells in the periphery into the brain and causes brain on fire, which is bandied about and is real. Okay, so the inflammatory markers getting there is real. There was a study looking at an MRI scan of somebody with mastocytosis, a malignant disease that's associated with lots of chemicals going around, giving the same symptoms of MCAS, and it compared it to an MRI of MCAS patient, and they were identical. And so there is real inflammation going on. There is real increased blood-brain barrier permeability. And I love DNRSR. I also mentioned Gupta, but I'm not as familiar. But neural retraining, getting a hold of the brain and trying to do things like ultra meditation is fantastic. Love it.
And you see it help with, I'm assuming, help to sort of attenuate some of this reactivity?
Absolutely. Yeah. Definitely is a great thing. A long time ago, a psychologist and I made an audio tape, CD actually, on hypnosis, self-hypnosis for irritable bowel syndrome, because I had heard that, 30 years ago that when you went to a doctor in Britain and said you had irritable bowel, they'd recommend as a first step self-hypnosis. So I'm all into it. But I think, IBS has come so much further with the antivinculin antibody and mast cell activation syndrome.
Sure. And just for our audience, these are both the DNRS and the Gupta, and there's other ones out there. They're limbic retraining, kind of this very intentional form of meditation that for some people can be quite helpful. And I just try to always underscore this because sometimes, and I'll refer our audience to a conversation from a year plus ago with Danielle, and we talked about this dance where I kept mentioning it and she kept interpreting it as Dr. Ruscio was saying it's all in my head. And then I'd sort of wait and she wouldn't do it. And then I'd friendly, in a friendly way, bring it up again. And after 6 months, she finally did it. And when she came back a month later, she said, holy smokes, this really helped. I wish I had done this on day one. So again, I just want to make sure to share that with people in case you feel like when someone says it's a brain-based therapy, it doesn't mean it's all in your head, but it does mean, again, there could be something in the mind that's leading to this really pro-inflammatory immune system.
So many of the patients see specialists. They see an ENT because they got tinnitus and ringing in their ears. They see a migraine doctor and get Botox because they have idiopathic or unknown cause migraine. They see a allergist because they've got hives, a rheumatologist because they have muscle tenderness, diagnosed fibromyalgia, gastroenterologist, IBS. You've got to look at the whole person and put all the symptoms together, do the test or treat, and diagnose MCAS, which is present in 17% of the populations. As I like to talk about Rodney Dangerfield in my talks, I have a picture of him, and it says, syndromes get no respect.
Right.
Those who are younger, he's a comedian that basically says, I don't get no respect, was part of his thing about his wife. But he was a fantastic, he was in Caddyshack, so it's relatively new. But
huge fan. Yeah.
Don't get respect. And it's sad. And that's why we're doing this documentary. We're bringing about awareness. The exciting thing with symptomatic, is the working title, is that it will lead towards awareness. And we want to get it taught in med school. And we're going to have a library, online library for people suffering, families not understanding, and hopefully physicians and medical providers up and down the spectrum to learn more. If anybody is interested in contributing towards high quality, hopefully a Netflix quality film, MCASfund.com, MCAS, FUND.com. Even $20 will take us a long way with enough helpers.
Yeah, times enough people, it really moves the needle. Yeah, I mean, great point. Don't think that a donation is going to be insignificant, because I mean, if you can donate more, please, but even $20, it helps for sure.
Yeah.
The other thing that I know is part of what you focus on in your clinical practice is, and as you've discussed already, SIBO, and certainly what's going on in the gut, the bacteria, whether it's SIBO, whether it's dysbiosis, whether it's neither, and you're just noticing a response to antibiotics or antimicrobials. There's something in the gut that can be modulated that really seems to move the needle for the immune system, for this reactivity. And I believe you've published on rifaximin in MCAS, I think with SIBO, but tell us a little bit about what you're seeing from this angle of, well, maybe there is a trigger, like you said earlier, that's not the paint from the paint salesman, but that is internal. And if we could weed out that trigger, boy, do we alleviate a huge burden.
Absolutely. Well, bloating is a very common symptom from MCAS. So characteristically, it's rapid onset bloating. A good example is a house inspector that would go into these old homes and that had a lot of mold. And every time he did and found that bad home and started to work on it, he'd race out, have severe pain, and vomit on the front lawn. And four times he went to the hospital and he had this markedly distended stomach, small intestine, and colon. And so he had underlying, subsequently I diagnosed him with MCAS, told him to get out from under the mold cloud and stay healthier. And he switched jobs. He got treated with mild treatment for mast cell, and he's totally asymptomatic. But with respect to bloating, yes, 30% of my mast cell activation syndromes had SIBO, 10% had methane plateau, which I view as a methane producing dysbiosis in the colon. And so that was higher than the 10% of controls who had SIBO. So statistically greater. But many times these patients have bloating because of a mediator or chemical induced paralysis of the gut or secretion of fluids. So some of my patients who come in with bloating, I tap on their abdomen and they're not like a drum tympanic. They're just solid, and therefore they have like fluid rushing into their gut lumen, distending it, and it does so rapidly. So,
Now,
yeah.
just one clarification here, because I've been trying to be a little bit more diligent about delineating some of the language. Distension as the appearance of a pushed out abdomen or larger abdomen, and then bloating more so being there could be the appearance of distension, but also some sort of discomfort or feeling of gas and pressure. Are you making that delineation? Does it not really matter? How do you think about that?
So if you think about it as just being the a dum-dum gastroenterologist, there are papers written to show that people who have abdominal pain from irritable bowel syndrome commonly get bloating and their abdominal wall muscles distend. And it's like
Right.
overeating at Thanksgiving. You have to undo your pants and bloat out just to decrease the pain sensation. Because if you wrap yourself up with a tight belt, you're going to be in more pain.
Right.
But take that aside and separate those people who distend just because they have pain, and those that are generating excess gas, um, and those who are generating relaxation or infiltration of fluid into their gut because of MCAS. So you
And
got three different.
they tend to be absent of pain. This other group, there's no pain, but there is the appearance. Or
There's
okay,
pain. So you got three different groups. You got your quote irritable bowel patient that gets distended and bloated, and we'll show you sometimes pictures of them looking at pregnant. You've got a
right.
true SIBO patient who responds within an hour, hour and a half with distension, excess trapped gas. You've got the dysbiosis patient who, let's say, makes methane and 2 or 3 hours afterwards gets actually bloated with gas. And then you've got the MCAS patient who spontaneously um, will bloat up, and that can be fluid. And then you have the crossover. Sorry to make it complex, but you've got the MCAS patients who've got SIBO. You treat the SIBO, that reduces the inflammation,
Yep.
reduces the cytokines that activate the mast cells.
And this comes back to the way I tend to think about these things hierarchically in terms of, start with the low hanging fruit, the diet, the lifestyle, treatments for SIBO or dysbiosis, even if presumed, and see where you get. And then if bowels are regular and they are demonstrating less, let's say, reflux and their mood is improved, but they're still having this distension, that cues me, and there's another layer that needs to be pursued.
Right, right.
And in those cases, you're finding sort of this complex of MCAS inflammation. And is this where you're reaching for the natural agents, the H2, H1 over the counter agents? Is there something in particular? Because I know a fair subset of our audience is plagued by this. They've gotten rid of most of their symptoms. There's still this distension. And I'm sure they're curious what you find helpful.
So patients will leave my office. Let's say they have IBS, quote IBS, and I'm suspicious of SIBO. They'll leave with the breath test kit, okay, and they'll return it, and they'll come back when they're handing in their 24-hour urine, and they've done their blood tests, and then that wraps up part of the workup. If they have restless legs syndrome, which is 40% of MCAS patients, according to a study we just did a couple of years ago, then we check vitamin D level and ferritin. With respect to what do we do? So if they're SIBO positive, we treat just like you would, but I may or may not use a prokinetic agent, because if I feel like the problem is SIBO and I can control the gut lining with a variety of naturopathic therapeutics, then I'll do that. The
Right.
endozyme, etc. So zinc, carnosine, even bovine immunoglobulin, etc. I want to treat that to heal the gut lining after a course of the therapy for SIBO. And then, I'll be using natural and over-the-counter therapies for MCAS in addition.
Are you coming back to ferritin for 1 second? Are you finding that typically high in this presentation?
Well, you'd like to think that and a CRP and an ESR would be high because it's inflammation, but it's not.
Inflammation can be tricky. Yeah, no, I hear you there.
Okay. But low ferritin have to be treated, or even anything on 50 needs to be treated for your restless leg syndrome patients.
Gotcha. Yeah, I know that there was a few papers. I think his name was Sapi. He was postulating underneath 100. And as we were following that, we felt that was too high of a bar. And we've been finding maybe closer to 30, but I think you got to be closer to the true lab cutoff. But 100 might be too steep. It might be a little overkill. So I'm with you in terms of 30, 50. That's probably when you're going to have a higher likelihood of seeing a clinical response.
Yeah, so Sun et al. Found that anybody 50 or lower with ferritin, 50 or lower with restless leg syndrome had more severe disease. So you want to get in the 75 range, whether you take
that's a great data point.
Oral or intravenous. And
you're wanting someone, you said, to get at least to 75. That's when you're happy.
Yeah, I'm happier.
Okay. Yep, that seems reasonable.
They're happier too.
You mentioned immunoglobulins, and I'm glad you mentioned that. It's one of the things I wanted to ask you because it has so much appeal from the perspective of deactivating LPS and these compounds, other compounds, not just LPS, but that can trigger the immune system and start this inflammatory cascade. And for our audience, we've discussed this in the podcast in the past, but the way I think of immunoglobulins is it's a supplemental form of the mucous membrane. And the simple analogy I use is it's like taking a shard of glass and covering it with wax. So as it slides through your intestinal tract, it's not going to nick things and trigger inflammation. So when someone has responded somewhat, but then there's still this immune reactivity, oftentimes with these histamine-like symptoms, that can be a really helpful go-to. Anything else that you'd want to add about immunoglobulins at all? I know you've researched. In fact, your paper from, what was it, 2018 maybe, was one of the more influential papers that really opened my eyes to the use of, at that time, prescription Interrogam, and now it's available over the counter.
Right. I love the shard of glass. It's a wonderful image. Basically, the chemicals, if you will, from broken down bad bacteria can be swallowed or deactivated by the immunoglobulins. And as well, the immunoglobulins can capture a number of other byproducts and allow the gut to heal. And this is basically goes back to now 40 years of veterinary medicine, where they took weanling pigs who were taken away from their mom, not allowed to have their mother's milk, and they were sick. And so once they thought, well, let's give them immunoglobulins that they're missing, and they all got better. And so then that led to applying it to humans, and it's a very good natural substance, unless you're vegan, because it comes from purified blood from cattle. There
is an egg-derived version of the immunoglobulins also for people who might be willing to acquiesce to consumption of eggs. Also, to tie in piglets as a weird segue point, but I was reading a study just recently that found sodium butyrate supplementation in piglets reduced mast cell activation and a few other similar markers. I'm not as hot to trot as some people are on sodium butyrate, although you're seeing some trials being published recently that I think make it worthwhile to at least experiment with. Have you used prebiotic or postbiotics in this case, butyrate or anything similar?
I'm getting ready to try it. There's only so many things that you can immediately throw at the wall and make it stick. Right. But what else do you have to treat for dysbiosis? Can you really influence the, levels of bacteria, perhaps by diet? We do know, in fact, that low-fat FODMAP diet improves dysbiosis, and the butyrate may reduce the effect of poor spectrum of bacteria or dysbiosis. But you're not going to give anybody a probiotic from the shelf that's going to make a lick of difference.
Well, two thoughts on this. With the
My
low
opinion.
FODMAP and dysbiosis, I know the probiotics is one of the few things we don't see eye to eye on. But with the low FODMAP, I'm so glad that you mentioned the ability of low FODMAP to rectify dysbiosis, because every once in a while you'll hear someone who says, well, I don't want to go low FODMAP because I heard it's bad for my gut bacteria. And understandable, that was a hypothesis from 5-10 years ago. But as we're learning more and we're researching this, and we just recently recorded a video on this, there is good evidence showing that low FODMAP can reduce SIBO gas levels, can correct dysbiosis, can improve leaky gut. It can also reduce inflammatory cytokines. And not only that, but can also lead to a somewhat normalization of enteroendocrine cells like serotonin cells in the gut. This is Tarek Mazalwi's paper from, I think, 2017, which I found really fascinating. So it's not to say you do low FODMAP forever, but I look at it as a corrective intervention. Oftentimes I use the analogy in our consulting practice of someone who sprained their ankle. We wouldn't want them running for a month or so, but it's not to say they can never run again. But if they keep running, they're never going to heal. That's how I look at the low FODMAP. You need that period to rebalance, and then you should be able to broaden your diet back out.
It bothered me that the Australians did not look at the incidence of SIBO in those patients. Because you're giving them fermenting food. And if you have SIBO, you're going to make SIBO worse. So that's number one. Number two, it does play a role in dysbiosis. And therefore, when the fermentation gets going in the colon, that's an issue by itself. As far as probiotic, I do use a lot of probiotics. And so I just never saw how probiotics by itself could necessarily improve SIBO, although prokinetic therapy or action by the probiotic makes sense to some degree. But I do believe in either herbal or traditional antibiotic therapy for SIBO.
Well, I'll leave the probiotic issue aside because I know we've discussed this in the past, and we have different perspectives on that, which is totally fine. No one's going to agree on everything. I think we agree probably on 90% of things. To pivot us over, because I do want to at least get a little bit on the most effective therapeutics you're finding for POTS and for Ehlers-Danlos. I'm curious, exercise for both of those. Now, I know, obviously, when you have a condition of hypermobility, if you do exercises that tighten the muscles, like resistance training, that's going to be a win. For POTS, I was doing a little bit of research this morning, and there's at least some inferential evidence showing that you can have a neuromodulatory impact with exercise. And I'm wondering, what's your perspective on exercise as it pertains to both of these, but most namely POTS, just because I think it's well agreed upon for EDS that we want to be using some sort of muscle building exercise.
Great question. So for POTS, it's simply reclining bike and swimming to build up the muscles so that when you stand up, the muscles surround the veins and allow compliance, if you will, artificial compliance, because your veins may not have good compliance. You also, of course, want to look at MCAS as the cause of POTS. We just published an article this year on patients with unrecognized MCAS, kind of like unrecognized MCAS in the setting of depression. But this was unrecognized MCAS patients who got Gardasil for HPV and then developed POTS. And basically, it was exacerbating all of their MCAS symptoms, and then it factored in getting POTS. So going ahead, let's go backwards to your question. EDS, physical therapy, critical. Patients have really improved with physical therapy. And exercise, there are certain exercises that are good, but anything that overstretches the joint is bad. As far as meds go, LDN and PEG for EDS joint pain is great. There's an article that just came out that LDN helped reduce the severity of POTS. So I love that article because that's been my experience as well. Does it improve mast cell reactivity, reduce mast cell activity, and therefore reduce that yin yang of the autonomic motor system? Probably. Right. Yeah. So that's some of what I would say in terms of pain and management for EDS and POTS.
And I'm assuming with POTS having sort of this component of dysautonomia associated with it, and knowing that there's some pretty compelling data looking at exercise, specifically moderate to high intensity exercise, either preventing PSD formation post-trauma if people are exercising and then they have the trauma, or as a corrective therapeutic after the trauma. It makes me interested to see how far could some of these people get if they worked up to more intense exercise. And I think the quagmire here can be sometimes there's been such a degree of fatigue and inflammation and symptoms, people get deconditioned and they try to exercise, they get sore, they get tired, and they get kind of scared off rather than looking at this sort of stair stepping your way up. And the way I think about this is I have some friends who are triathletes. They didn't go right to that load. They had to maybe spend 6 months to a year to be able to accommodate and work up to that load. And I think we're all on a scale. And my concern is that sometimes people are not very well conditioned and they don't realize it's a slow sort of staircase that you have to ascend to get there. But we don't see a lot of POTS. So I'm curious if you have any observations here.
Well, first of all, POTS is 1% of the population and primarily in women. So it's out there. With respect to the idea of exercise and running and so forth, you don't want to pound the joints or do ballet or do athletics like gymnastics if you've got EDS and overdo it. And all the best gymnasts are, in fact, EDS patients. But, there are ways to do it safely and ways not to. But
so I'm assuming something like a resistance circuit of some sort where you're lifting things, but there's not a lot of impact.
Right. Now, you mentioned the value of long distance running, and basically that boils down to endorphins. But why don't you take endorphins every day in the form of low dose naltrexone?
Sure.
Since 2005, I have been an LDN nut, if you will say. I've been an enthusiast. I've seen such dramatic improvement in patients, in x-rays, in skin exams, in life histories, in my own wife who has taken it for 11 years to treat and cure her or put herself into remission with restless leg syndrome. You don't get that with any drug that the FDA has approved for restless leg syndrome. They're all crap. LDN, just read the LDN research study, the LDN researchtrust.org. Look at my website. I think you'll be impressed. I'm not pushing it. It does have like 15 to 20% of people can't tolerate it because of the endorphin rush. They get vivid dreams, insomnia, and jittery. But 85% can tolerate it, and usually 60% people get better.
Yeah, I mean, looking to pick your brain and your clinical experience. So, preach on regarding the LDN. And maybe the final point here before your battery dies is salt. I think I'd be remiss. I think would be remiss if we didn't mention that. Well, sometimes salt is vilified. Like, pick any food and it's going to get lumped in this guilt by association, straw manning. But for POTS patients or patients, maybe they don't know if they have POTS. They get dizzy when they stand up quickly, sort of syndrome. There's some fatigue, there's low blood pressure, and they might be kind of shy on salt. And for these people, boy, giving them 1, 2, 3, we often use the LMNT packets a day can be a game changer for some of these people.
Absolutely. That, and also binding clothes, the support
Compression
stocking,
socks. Yeah.
right, cooling vests. People even use their compression on their arms as well, just to get that blood from the periphery back to the heart and brain. That's
Right.
what it takes sometimes. Because
Right.
there are about 6 different causes for POTS. Just look in the literature; it's been described with Lyme disease, with a genetic disorder, familial, neuro. Endocrine phenomenon, synapses that you don't reabsorb the fluid from your body well, and therefore you're dehydrated, so decreased volume, and ED, and also, of course, MCAS. So
Right.
there's not one thing, and then autoimmune causes as well. So there's
Sure.
6 different causes.
And also maybe some that are a touch less benign. And this is maybe a bit theoretical. I don't know how well this has been formally studied, but if people are under a lot of stress, then they may not have good release of aldosterone. They may not be retaining a lot of fluid. And if people are not eating enough, or especially if they're low carb, and for some people, they may be very restrictive due to not feeling well and inadvertently going low carb. We see a fair subset of these people. And boy, that's where salt can really bring them back to life.
Right.
Lenny, will you remind us the documentary, where they can donate, your website, anything else that you want to point people to?
Yeah, we're starting to film in December. We want to make a high quality film. We want to help patients. It's going to be an inspiring film called Symptomatic as our working title. MCAS Fund, MCASFUND.com, MCASFund.com. And I thank you very much for allowing me to give a plug for something that's going to help so many people and so many women.
Yeah, absolutely. I mean, I appreciate the work that you're doing. I really think you're one of the good guys in this space, both doing the research and in the clinical trenches. So keep it up. It's always a pleasure chatting.
Thank you so much, Michael.